Right. Good evening, ladies and gentlemen. Karibu, and a warm welcome from the EMGuidance team. I'm your host, Jonathan Katende, being the marketing lead at EMGuidance. I'll tell you a bit more about our platform, but this is just a warm welcome to everyone in Kenya, and we trust that you'll find this CPD webinar insightful. Thank you. So just to speak a little about EMGuidance, the sponsor of the CPD webinar. Essential Medical Guidance is a platform that was founded in 2016, and it has become the most comprehensive digital source of locally relevant medicines information and clinical guidelines in Africa, with over 31,000 local healthcare professionals on the continent. In addition, several medical societies, the National Department of Health in South Africa, and medical companies educate and communicate to medical communities throughout EMGuidance. We've recently launched EMGuidance in five new African countries: Kenya, Nigeria, Botswana, Namibia, and Ghana. And for those of you who are new to the EMGuidance family, we would like to welcome you to this webinar. The purpose of this webinar essentially is to add value to healthcare professionals in Kenya, provide the latest pharmacology information, and build a healthcare community. Tonight's webinar format will be quite simple. I will, of course, as you can see, introduce our host, go into the core of the webinar, and provided we have some time, have a Q&A session towards the latter part of this session. Some of the house rules: you can ask your questions using the chat functionality available on your screen. This webinar will be recorded, and we will be uploading the session on the EMGuidance platform. Secondly, thank you to our partners, the Kenya Medical Association, who will be accrediting this CPD webinar. And should you guys have any issues receiving your points, kindly just send me an email at jonathan@emguidance.com. Before I introduce our speaker, it's important to mention that Google, kindly just have the platform on your mobile. I repeat again, the session will be loaded on the EMGuidance platform, and you'll be able to watch it there and receive your CPD points there. Now, without further ado, I'd like to introduce our speaker today. Professor Mohammed Iruma is an associate professor. He's an independent specialist clinical pharmacologist, the Secretary General of the College of Clinical Pharmacologists at the College of Medicines of South Africa, an academic lecturer, and a researcher at the Faculty of Health Sciences at the University of Witwatersrand, an honorary senator, examiner, educator on both the American College of Clinical Pharmacology and the American Board of Clinical Pharmacology. Prof. Iruma is also a global educator with the EIT, European Institution of Health and Innovation in Technology, and the Middle East and North Africa Clinical Pharmacology Society, and the co-editor of the South African Medicines Formulary. Lastly, he is the clinical pharmacology of EMGuidance, and we're honored to have him today, and we look forward to this presentation. Over to you, Dr. Iruma.
Thank you so much, Jonathan, and welcome to all our audience from Kenya, from Africa, from everywhere, and welcome to the EMGuidance family. My name is Professor Iruma, and today I would like to learn with you because I believe that it's always learning better when we learn together. My presentation might look simple on the title, which is the guidelines to the rational prescribing, and we'll try to use some case study approach in order to shed the lights on the importance of the rational prescribing when it comes to seeing your patient and toward the direct patient care. Now, for every healthcare professionals, this is what you always consider as a prescription. It's the piece of paper that reflects the date, the patient's information, including the name, the medication that you are about to prescribe for your patients, including the medication's name, the strength of the medication, the frequency, the duration, your beautiful signature, and your healthcare professional contact details. What I've noticed during my 15 years plus in pharmacology and 5 years plus of a clinical pharmacology specialist career is that sometimes the prescription could be unidirectional. Yes, our ultimate aim is to use it as a tool to help our patients, but sometimes we are helping our patients to fulfill what we call the shopping list, especially when the patient seeks medication, not because there is a pathophysiological problem that we need to treat, but the patient's been taking this medication for decades, and he or she may think that is treatment for life. And also, as a healthcare professionals, we always tend to prove that we have successfully delivered the services, and our prescriptions sometimes being misinterpreted as a proof of delivery, of successful delivery of our healthcare services. But in my opinion, the prescription is not only a helpful tool to manage your patient, it is in fact a legal contract between you, your patient, patient's relatives and family, the pharmacist, the society, the National Department of Health, and everything. It is a commitment because each and every single letter or digits you ink inside this prescription, someone's life may depend on that information. And also, to preserve our reputation, successful treatment means successful delivery, means successful repetition. If you investigate what does prescription of medicine mean, it's not a simple procedure. It's in fact a complex process involving the initiation, the monitoring, and also the continuous modification of the treatment. It's never once-off delivery. It demands a thorough understanding of clinical pharmacology, as well as the judgment and the ability to prescribe rationally for the benefit of patients, patients' family, and the society. Prescription can take different formats. Traditionally, we always known to have this A5 prescription pad that we tend to give to our patient towards the end of the consultation. But the prescription could also be the information that you write down in the blueprints in your patient's file in the hospital. And hopefully, in the near future, prescription could be no more than QR code that the patient receive, scan at the allocated specific pharmacy, and dispense the medication. And this could be the future tools, not only to ease the work for the healthcare professions, but also to minimize the error of prescriptions. Should a prescription contain wrong information, wrong medication, wrong dose, etc. The prescription is a reflection of your professionalism. It's one of the main things having increased the burden on health economics. Should you prescribe more than single class of drugs, or what we call polypharmacy? Anything goes wrong with the prescription, it could have affected the healthcare profession's reputation, or even dismissal from the Health Professional Council, should it reach the legal or medical legal borders. For all of us, we always think prescription is easy. Write it down, write it neatly, give it to the patient. But in my career, I always teach my students at the academic space, is writing prescriptions like mapping a detective case. You have to link all the puzzles. You have to look in details of your patient's information, the way that your patient's been reached the diagnosis, the pathophysiological issues behind the pathology, the contraindications, the possibility of the drug-drug interactions, should your patient take in more than a single drug. And more importantly, you should tell your patient when they stop the treatment. Because unfortunately, we're so great in initiating therapy, but sometimes we tend to forget that that therapy should not be for life. And patients need to know at what point he or she must stop the treatment and at what point he or she must come as a follow-up. So as I promised in the introduction, let's use some clinical cases. These cases, in fact, are from the reality. These are the cases I've been seeing over the past 10 years. And I would like to shed the light on how can we improve our prescription rationally by considering certain elements that most of you may know, but some of us may not. Here is Norman an 8-month-old boy, recently admitted to the hospital, and the provisional diagnosis was respiratory tract infection. Upon examination, he was feverish, he was tachycardic and tachypneic, with some chest indrawing and sign of malnourishment. The rest of the laboratory test was normal, except the fact that the serum creatinine was slightly increased, and the child suffered from hypoalbuminemia. Most of us knows that this could be a physiological hypoalbuminemia and is not pathological. So the treating team decided to start Norman on gentamicin. Checking the local protocol, it was 5 milligrams per kg. They started the infusion every 12 hours, and they start monitoring the child. Now, the biggest problem here is that Norman, upon receiving the 3rd dose of gentamicin, his temperature reached beyond 40 and shortly developed urticaria-like rash. Now, what could possibly go wrong, and why Norman had developed the rash after the 3rd dose of gentamicin? This is a snapshot from the EMGuidance. And upon looking at the adverse effects of gentamicin, you could have clearly see that under the skin and subcutaneous tissue disorder, rash is being considered one of the common adverse effects. So what's special about children? Number one, we have lots of challenges. The vast majority of the clinical trials, due to the ethics requirement, only done in adults. Extreme ages, pregnancy, breastfeeding, patient with immunosuppressions, usually excluded from clinical trials. And for that reason, most of the medication we have, the recommended dose came from the adult dose. Now, with the children under the age of 6 years, you cannot expect all the organs to be functioning at 100% capacity. There is immaturity in the liver function. There is immaturity in the kidney functions. The proteins may have a certain capacity to carry those medication with high plasma protein binding affinities. And also, the volume of distribution of certain medication may varies according to the child's age. And for that reason, it's quite difficult to come up with recommended dose in children simply because those clinical trials were done in healthy adults. And finally, the complication could be the lifelong penalties. Imagine giving tetracycline to a child when the main adverse effect could be a permanent discoloration of the teeth or retardation of the long bone growth. What happened to Norman here is that one of the main parameters of the pharmacokinetics, and for those who doesn't know, the pharmacokinetic is the relationship between the body and the drug and the effect of the body on the drug. Children under the age of 2 years tends to have a high percentage of body water, especially in the neonates. A drug like gentamicin, which belongs to the class of aminoglycosides, have a massive distribution in the high water environment. And this is exactly what happened to Norman here. Upon the 3rd dose, gentamicin was everywhere, which increases the chances for Norman to develop skin rash. For that reason, you have to be careful about this medication, and those adjustments should be considered. Children also have a membrane permeability because a structure like blood-brain barriers, which is supposed to protect the central nervous system from the neurotoxic medication, is immature. And neurotoxicity, usually with antimicrobial and antifungals, is quite high in pediatric. As we said, due to the immaturity of the liver function, the liver or the hepatic tissue is unable to produce enough albumin. And for that reason, sulfonamides, for example, when they're given to children in the past, it's causing neonatal jaundice or called kernicterus. Because what it does, the sulfonamide tends to displace the bilirubin from the binding side of the plasma proteins, and now the child will have a free circulating total plasma bilirubin, which reflects into neonatal jaundice. We talk about the liver immaturity, and it was one of the reasons why drug like chloramphenicol causes gray baby syndrome. It's very important also to note that within the first 2 to 3 months of the after delivery, children usually tested for the G6PD deficiency. If at any child having a G6PD functioning at the level of less than 25%, there's certain medication may tend to cause hemolysis, hence bleeding. And this medication includes chloramphenicol as antimicrobial, dapsone, cotrimoxazole, which is in the market known as a Ciptrin or Bactrim, and also quinones. And as you can see here from the EMGuidance app, one of the main cautions when it comes to drug like cotrimoxazole, which is known as sulfamethoxazole and trimethoprim, is a G6PD deficiency. Lastly, when it comes to the elimination of the treatment, gentamicin, usually the excretion of gentamicin depends on the maturity of the kidneys. Norman was 8 months old, and for that reason, the capacity of his renal function system to eliminate gentamicin is a bit slow, which reflects on increasing the half-life of gentamicin. Pharmacokinetically, half-life is defined at the time it takes for the drug plasma concentration to drop by 50%. And each drug required 4 to 5 half-life to be completely eliminated. So what happened to Norman here is that he has a volume of distribution of aminoglycosides because of the water structure and a poor kidney function due to immaturity to eliminate gentamicin, which hence reflects on the urticaria-like rash. The main issues with dosing in pediatric is, please guys, do not use age and never guess. The lovely picture of the two children you see on the screen, these are actually twins. If you look at the body size of the boy on the left side, comparing to his sister on the right side, it's clear that using an age to dose children is a big mistake, because the boy on the left side may require the higher dose than his sister. The main recommended formulation to dose in pediatric is easier, milligram per kg, or when it comes to certain medication like immunosuppressant and cancer chemotherapy, the body surface area is very important. There is some exception to this rule. If you look at the treatment of HIV and TB in children, we tend to use weight band charts. That's fine because that's going to ease the way of prescription. But never use age, never guess what could be the next dose for your patient. Now let's move to the next case. We have Nitesh, a 75-year-old with history of the heart failure and hypertrophied cardiomyopathy. Nitesh currently taking Digoxin, which is one of the medication known for the conditions like heart failure. It's also known with its very narrow therapeutic index, which means any small increase in the Digoxin dose may lead to a higher plasma concentration and hence toxicity. Nitesh recently been prescribed clarithromycin, a macrolide antimicrobial at a dose of 500 milligrams twice a day for a bronchitis. 4 days later, Nitesh was hospitalized and complaining of nausea, vomiting, weakness, and a presence of brown spots in the visual field. The intern at that time thought this is just a food poisoning. He runs ECG. He managed to pick up the borderline first degree AV block and the left bundle blanche block. The rest of the lab result was fine. And when the intern escalated this case to the registrar on call, they suspected digoxin toxicity. The serum digoxin level was 4.8. And for the references that we use in South Africa, the therapeutic window should be between 0.6 to 1.5. On admission, Nitesh digoxin level was 5.4. It's almost 6 to 7 times above the level of norm. So what could possibly go wrong? Each time I show this slide to my student at Wits University, everyone will think about drug-drug interaction. That's correct. But unfortunately, Nitesh was a victim of malpractice. Because if you look closer in the second line, he's been giving antibiotic for bronchitis, a self-limiting condition that could be cured by a beautiful hot cup of tea with honey, or some of the corticosteroids orally for a couple of days. Clarithromycin is known to be a cytochrome P450 enzyme inhibitor. It's also a transporting protein caused as a PGP inhibitor. And for that reason, it's not only inhibits the metabolism of the digoxin, it blocks the digoxin from leaving the body, which contributes toward toxicity. Elderly usually have a low activities of the cytochrome P450 due to its senility. And for that reason, when it comes to drug metabolism, you have to check the drug-drug interaction. Here's a beautiful snapshot from the EMGuidance interaction checker. And without a doubt, you can see the moment you write the two medication, clarithromycin and digoxin, you could have seen more than a single mechanism by which the clarithromycin may contribute towards digitalism or digitalis toxicity. If anyone run this drug checker prior to prescribing Natash those medication, Natash could save himself a more hospitalization or even more worse death. Elderly is also challengeable because when it comes to the renal system, it's always difficult for the elderly to excrete medication due to decreased kidney size, due to the low blood flow in the kidney, due to decreased tubular secretion, and also senility-induced reduced glomerular filtration rate. Certain medication, there is lots of cohort study indicates that some of the medication, the clearance of the medication may be delayed. These include aminoglycosides, antimicrobials, beta blockers like atenolol, and cardiac digitalism like the digoxin, allopurinol, and quinolones. So as you can see, Natash's problem here is that the drug, which is clarithromycin, worked as an inhibitor, preventing the digoxin from getting metabolized and hence detoxified. But on the other hand, he's also an elderly patient for which the clearance of the digoxin is also very slow. For that reason, with elderly, it's very important and crucial to have a look on the creatinine clearance. Guys, never ever use serum creatinine or urea as an indicator, because in elderly, you may get a wrong reading. We've run a clinical trials in the past by UCT, the University of Cape Town, when we found lots of elderly, despite the fact that their serum creatinine was within the normal range, their glomerular filtration rate was deteriorated, simply because elderly have a low lean body mass, which contributes towards low creatinine production. And for that reason, in order not to have any masked laboratory results, either you have to calculate the creatinine clearance, or most of the systems in Africa can automatically estimate the glomerular filtration rates in order to make sure your patient is eligible for taking that medication. The American Geriatric Society in 1991 came up with a beautiful criteria called Beers criteria, which is a criteria for a potentially inappropriate medication prescribed in elderly. I was having my own concern about this criteria up until the 2017, when it was an evidence-based, and the latest one belongs to 2019, that was published last year. Here is an example of how you can use Beers criteria. If you look at medication that most of the geriatric patients use, for example, benzodiazepine, either for insomnia or even for anxiety, elderly have a high sensitivity to benzodiazepine. And why this is very important? Because the main side effect of benzodiazepine is respiratory depression. And for that reason, what you may think it's something going to help that elderly person to fall asleep, it could be a recipe to terminate his or her lives. So it's very important to find resources and find the eligible resources to rationally prescribe your medications toward elderly. Now let's move to the next case. Here is Wendy, a 25 years old. Wendy, she has a history of partial epilepsy, but now she's brought by the paramedics to the ER rooms and presenting with what looks like a generalized tonic-to-clonic seizures. Wendy, she's known to be epileptic, and over the past 3.5 years, she's been on lamotrigine, an anticonvulsant medication known to inhibit the sodium and calcium ion channels, for a couple of years. And it's very important when it comes to epileptic patients that if they've been using the same medication over years and they never have any breakthrough, it means they've been compliant and adherent to the medication. Now, the issue is that while Wendy was hospitalized, the on-call nurse discovered after running a pregnancy test that Wendy was having unplanned pregnancy. So the first question you ask, please don't ask who's the father, but how can we help Wendy? Before the year of the 2015, the FDA used to have an alphabetic system in order to categorize which medication is safe to be used during the pregnancy and which is contraindicated during the pregnancy. All of you knows about the alphabet A, B, C, D, and X. When A and B are safe to be used during the pregnancy, C have to be used with caution and only when the potential benefit may warrant the use during the pregnancy despite the relative contraindication. D is you only use it when you don't have any resources and it's a life-saving for your patient. And category X, for example, atorvastatin or statin in general, and even the ACE inhibitor, are the medication that you must not use at any circumstances. In 2015, the WHO decided to move away from the alphabetic system and start introducing the PLLR, which is the Pregnancy and Lactation Labeling Final Rules. In new system, instead of including the alphabets, you have to tag all the information regarding pregnancy, lactation, and the male and female reproductive potential. I think it was great because it gave us the chance for the healthcare profession to interpret the situation case by case. I was a bit surprised, and I must admit I was a bit frustrated because they mentioned lactation, not breastfeeding. Lactation is a process of producing milk for a pregnant and non-pregnant women. So they should have considered breastfeeding because that's when the risk of the transmission of medication from the female biological environment into the infant's biological environment. Other than that, I think this system is great. And we, the EMGuidance, have included this one since the last year, 2019. Here is a snapshot from what Wendy's been using, the lamotrigine. And as you can see on the right side of the screen, it's cautions, but there is no data voted against the use of lamotrigine. However, you have to look at the plasma level of lamotrigine because during the pregnancy, a female average weight gain is between 8 to 15 kilograms. And for that reason, the volume of distribution of a drug like lamotrigine could be increased. Should the treating physician decide to increase the dose, remember, lamotrigine is one of the medications can cause a devastating cutaneous condition known as Stevens-Johnson syndrome. So you have to be very careful. Now let's see the next patient. Here is Kim, a 30 years old female patient, a first-time mother, and now she's at the 16th week of gestation. Kim, she has a history of depression. She worked with a company for more than 5 years. It wasn't a pleasant environment, and for that reason, her mental status was a little bit at challenges. Now, Kim is currently taking fluoxetine. An antidepressant medication belongs to the group of the selective serotonin reuptake inhibitors, or we know as SSRIs. Now, Kim's problems and concerns that should she continue taking the medication because someone on Facebook has posted something regarding if the nursing mother continue taking its antidepressant, there is a chance for the drug to be transferred from the mom's milk to the child. Now, Kim had a big problem. Should she continue taking the medication? Because she thinks, based on experience, that if she stopped the fluoxetine, the depressive symptoms will come back. And she worried about any suicidal thoughts, which she had 3 years ago before joining her company. Also, Kim was worried upon Googling the information, she found that the postpartum depression is quite high in South Africa. And for that reason, what will happen if Kim stopped taking her antidepressant? And what will be the solution? The solution could be, some of us say, don't worry, go ahead and continue. Others will say, nah, stop taking the fluoxetine and just switch the child into formula. We don't know if Kim can afford the formula, and we don't know if Kim can stop the medication. So what should we do at this stage? You check the resources. If you look at the EMGuidance regarding fluoxetine, we found that in the breastfeeding, fluoxetine is not recommended to be used. So perhaps Kim may benefit from switching to another agent. Most of the SSRIs like sertraline, fluoxetine, citalopram, escitalopram, and the dry cyclic antidepressants, something like imipramine or amitriptyline, are actually not recommended during the pregnancy and breastfeeding. Maybe Kim will benefit from something like mirtazapine, which is one of the atypical antidepressants that can be safely used during the breastfeeding and lactation. There is lots of the long list of medication causing depression. And as you can see, these are the medication that perhaps most of your patients been taking. Prednisone, glucocorticoids, methylphenidate, which goes in the market in the name of Ritalin and Concerta, the antipsychotic risperidone, amlodipine and some of the calcium channel blockers, methyl-dopa, an antihypertensive usually prescribed during the pregnancy, propropion, an atypical antidepressant, alprazolam, a benzodiazepine, esomeprazole, a proton pump inhibitor, otoricoxib, a selective COX-2 inhibitor, metronidazole, an antibacterial agent, and also contraceptive pill. We are not safe from that, and for that reason, please think before you give your patient something that may increase the chance for postpartum depression. Our next victim here was Tasha. Tasha is 24 years old. She has a healthy baseline. She's a lovely girl. However, since April this year, she's been passing through a very hard time due to the lockdown. And to add insult to Tasha's injuries, she also found, upon looking at her boyfriend's Facebook, that her boyfriend was cheating on her. Now, in July, after the lockdown regulation was eased, Tasha managed to see a psychiatrist whom diagnosed Tasha as a case of insomnia and major depressive disorder. Unfortunately, the psychiatrist forgot to do something called suicide intent scale, a scale that actually could have categorized your patient to a high risk for suicide or low risk for suicide. I personally recommend using the Edward Bears one. You can see the link in the presentation here. It's just a couple of questions with rating from 0 to 1 or 2, and the higher the grading you have, the higher the chance for the person to commit suicide. Usually 0 to 4 means the person is very unlikely to commit suicide. 4 to 6 is a borderline. Anything above the 10 or 11, it's a high risk for suicide. And for that reason, you have to be careful because certain medication may increase the chance for the suicide ideation. Tasha also have another trouble because the doctor started her on a selective serotonin reuptake inhibitor, and now she has to increase the size of her pants because she gained 6 kilograms. And I think Tasha was a very fantastic person because she managed to take a revenge by dating her the best friend ex-boyfriend, and now I think she's coming back to normal. Sometimes treatment should not be the necessary tool to help your patient. How can we determine which medication we have to give to Tasha? If we run the suicide intent and Tasha scored less than 4, then you start normally with the SSRIs. The tricyclic antidepressants are great, but there is a contraindication of using these medication. Elderly should not take this medication. Patient with suicide ideation or thoughts should not. SSRIs can also relatively contraindicate in suicide ideation, but the risk with tricyclic antidepressants is quite high. And patient with comorbidity like ischemic heart disease, heart failure, uncontrolled blood pressure, benign prostatic hyperplasia, and glaucoma are relative or absolute contraindications for using the tricyclic antidepressant. The American Psychiatric Society recommended that should you treat your patient, you have to keep a window between 4 to 6 weeks before you render the treatment failure. Unfortunately, your patient took the medication for 2 weeks, come back and said, I'm not happy. You should send the patient back home and said, you have to be patient, because what you are aiming to do is to restore the reservoir of the serotonin, the main neurotransmitters, which is being blamed based on the monoamine hypothesis as the main factor for why people do develop depression. Should you suspect bipolar disorder, you must refer to the psychiatry. Now, our next patient is Mohammed. He's a 44-year-old, recently diagnosed with pulmonary tuberculosis. Mohammed tested negative for HIV, and after starting the anti-TB regimen, Mohammed went back to the TB clinic with severe nausea, vomiting, abdominal pain, and a clinical jaundice on a sclera. Mohammed has a normal baseline, but he noted in his file that about 6 years ago, he has some fatty changes in his liver as per the previous ultrasound reports. The symptoms started almost 3 weeks after Mohammed started his anti-TB medication. And the liver function test revealed a massive increase in the ALT transaminase, a slight increase in the AST, and a massive increase in the total bilirubin. The rest of the investigation, including the full abdominal ultrasonography, was irrelevant. Liver is the main organ responsible for the metabolism, and there is lots of medication can impact how the metabolizing enzymes function. Some of them may increase the number of the enzymes, and we call them inducers. The famous example to that is rifampicin. Others may inhibit these metabolizing enzymes. And a famous example to that is what we mentioned earlier, the clarithromycin and the antifungal medication. We have a list of hepatotoxic potential medication. The anti-TB rifampicin, the isoniazid are the main one in the list. The antiretroviral nevirapine is also a hepatotoxic medication. And as you can see, the list can go on and on. But what is happening that if you remember from the case of Mohammed, he has a fatty liver, an element of fatty liver since 2014 that could have actually increased over that period of time and adding insult to the injury. Should a medication causing liver injury, there's a new terminology adopted by the American Society of Hepatology called a DILI, drug-induced liver injury. And there is a criteria for that. I don't think we have the time to talk about it, but should you expected that, especially with tuberculosis, the main medication that can be blamed to, including rifampicin, isoniazid, pyrazinamide. These are the three medication out of 4 that you can give in the initiation phase. Apparently, after 2 months of successful therapy, you can just continue on the rifampicin and isoniazid. But Muhammad's symptoms started 3 weeks after initiation of the treatment. Is that okay? This is when rationally you have to look at evidence. We have 2 famous studies, the Turkish study by Tahagulu and the Indian study by Sharma indicated that the mean time for the patient to develop TB drug-induced DILI is between 17 to 23 days. And I think in case of Mohammed, it was quite clear this is a drug-induced liver injury caused by the rifampicin most likely. There is a criteria to clinically define DILI according to the South African HIV Clinician Society, and that's either you have an ALT of more than 120 plus symptomatic patient, or ALT of more than 200 an asymptomatic patient. In Muhammad's case, if you remember, he has an ALT of 265 with total bilirubin of 34. He ticks all the boxes that this is a rifampicin most likely induced DILI. Our next patient is Victor. Victor is an 81-year-old elderly. He's a former technology guy and known to have a cardiac disease, rheumatological problems, and also known to have type 2 diabetes. Now, Victor's been recently seen by his GP. And because of the symptoms that Victor gives to his GP, that he got a burning feeling each time he urinates and some slight flank pain, the GP decided that this is a cystitis. And for that reason, Victor has been sent home with ciprofloxacin 500 milligram twice a day for 5 days. Unfortunately, 4 days later, Victor has been hospitalized and passed away. Rest in peace, Victor. So what went wrong here? The most important concept that any healthcare profession need to realize is that there is a huge difference between a healthy kidney with a nephrotoxic drug and a sick kidney with a normal drug. Patient with sick kidney, what we call the renal impairment, any medication must be looked closely and carefully before we can give that to the patient. On the other hand, there is a list of medication known as a nephrotoxic medication. I'm going to talk about it, which is in the normal situation, they may induce toxicity despite the fact how healthy the renal system is. This is the formula that if you don't have the technology, luckily enough, the EMGuidance can do it for you. But this is how can you estimate the glomerular filtration rate? Because according to the UK system, the UK guideline of managing patient with renal impairment, here's the categorization about when your patient could be called a mild, moderate, severe, or established renal failed patient. As you can see, the list of the nephrotoxic potential is quite extensive, including the most of the non-steroidal anti-inflammatory drug, the aminoglycosides, the glycopeptides like the vancomycin, ACE inhibitor, tenofovir as an antiretroviral, metformin, etc., etc., etc. If the healthcare professions who look after Victor had a tool like EMGuidance, he could have picked up that ciprofloxacin dose need to be adjusted accordingly, because in elderly, the elimination of the ciprofloxacin, despite the fact that it's a nephrotoxic agent, is required. Let's move to our next patient, which is Neil. Neil is a 37-year-old. In 2017, he was diagnosed with HIV and been started on Atripla, a fixed combination antiretroviral containing FTCs, DTF, and efavirenz. 13 days after the initiation of the treatment, Neil presented to the emergency room with a clinical picture of agitation, impaired concentration, hallucination. His GCS was about 8. They even intubated Neil, and 2 hours later, he started having convulsions. Everyone was worried about Neil may be a drug addict. Toxicology screen was negative. Cryptococcal meningitis has been excluded by the MRIs and also the lumbar puncture. CRP, white blood cells, everything were unremarkable. But there's one brilliant doctors like our Kenyan healthcare professions has picked up the fact that could it be the efavirenz? And the answer is yes. Efavirenz is one of the antiretroviral medication is known to cause a massive central nervous system conditions, including mania, psychosis, suicide ideation, delusion, vivid dream, and even aggressiveness. And for that reason, they switched Neil from efavirenz, which is the neurotoxic agent, into nevirapine. The only situation that you can't switch to nevirapine if Neil have any hepatotoxicity, because nevirapine is a hepatotoxic agent. Neil had survived and he continued successfully with his antiretroviral medication, and currently he's viral suppressed with CD4 count is more than 1,000 and the viral load is undetected. Here is the studies. Sometimes for you to be rational prescriber, you cannot only rely on a drug index. You have to look at the study. I just highlighted the keys for the main study that is being currently on the clinicaltrial.gov, and these are confirmed why drug like efavirenz by different mechanisms, as you can see on the screen, is attributed toward neurotoxicity. And as I mentioned with Neil's case, he's been switched from efavirenz into nevirapine according to the previous study, and he's doing absolutely fantastic. So what is prescribing? To me, you must treat medicine prescribing the same way you treat your online banking. No one will share the credentials of their online banking. No one will rush into writing the username or the password because you only got 3 attempts. After that, your online system will be blocked. If that's the time or the average time for you to log in into your online banking is between 30 seconds to 1 minute, think about the patient. They deserve more attention because blocking your online accounts is manageable issues. All what it takes is resetting the values or consulting your bank. But prescribing the wrong medication could have led to comorbidities, hospitalization, or loss of a life that somebody else may dependent on that. My second message to you, my colleagues, is that practice using the generic names or the international non-property names. This is the chart I just wanted to amuse you, is that this is the common medication usually you see. We tend to give lots of babies antimicrobials. By the age of 4 to 12, our children goes to methylphenidate, known as Ritalin and Concerta. When our young lady wants to start gaining weight in the high school, phentermine or Duramin is a drug of choice. Then when we go to the business or the university, start inheriting depression and anxiety, antidepressant and anxiolytics are the situation. Gentlemen like us by the age of 40 who try to perform great behind the closed doors, sildenafil as a Viagra could be the seeking. And as the patient reaching the age of elderly above the 65, you can name it, everything, and not including medications only. The injury can be insulted that elderly usually use complementary and alternative medicine. Garcinia, cod liver oil, selenium, echinacea, St. John's wort, saw palmetto, a recipe that we have no database to tell us, are they safe or not safe? Are they effective or not effective? Or if there is any potential interaction with the chronic medications. My fellow healthcare professions, our take-home message today, always consider non-pharmacological therapy. Treat your patient based on the pathophysiological basis. Understand the condition. If the condition is the bronchial asthma, you know there is 2 elements here, inflammation and hyperactivation of the autonomic nerve system, or what we call the 3 S's. The first S is for spasm. For that reason, you give the beta agonist as a bronchodilator. The second S and the third S for secretion and swelling. For that reason, you have to give anti-inflammatory. And that's why the most successful reliever in a bronchial asthma is the combined inhalation of the long-acting beta agonist and inhaled corticosteroids. When you understand the pathophysiology of your patient, you'll have a better understanding on how to approach the pharmacotherapy, not only safely, but rationally. Always consider rational and cost-effective therapy. And when we say cost-effective, it means less is more. If you can achieve the whole situation by one treatment, that's a win-win situation. Should your patient suffer from depression, having some joint pain, and suffering from insomnia, and there is no suicide ideation, then a drug like amitriptyline, a tricyclic antidepressant, could do the job. But what happens? You give the patient escitalopram, an SSRIs. Then you give the patient alprazolam, the benzodiazepine. And then you give your patient something else like propropion as a typical antidepressant. That is polypharmacy, my colleague. And that's not rational. That's shopping for medication. My fourth point, train yourself to write generics. Say carmoxyclav, do not say augmentin. Say methylphenidate, do not say Ritalin and Concerta. Write phentermine, don't say Duramin. Write escitalopram, not Lexamil. Write sildenafil, not Viagra. Because this is not only may imply that you may have a conflict of interest with those pharmaceutics, but think of the fact that when generics started to see the lights in our lives, it also relieved the stressed or already stressed healthcare system. Please use resources. EMGuidance got your back. We recommended EMGuidance not because we have everything, but we try to use every single element of evidence-based medicine to make you perform safely and make you perform rationally. And my last advice to you, before you write the drug first letter, think before you think. Every single patient walks through the emergency room's door or your clinic door is a special person. There's lots of data shows that actually we are genetically different. The 500 milligram that killed Victor of ciprofloxacin could have saved his life if you dropped that dose by 250 or even consider a non-nephrotoxic medication. Should you individualize your script, you're not only going to perform a rational prescribing, but you will be a very successful candidate in our healthcare society. And having said that, thank you so much for listening to me. This is Professor Ruma from the EMGuidance. I would like to hand you back over to Jonathan. Thank you and have a good night.
Thank you, Prof. Aruma. That was incredible. And I hope you guys found it as informative as it was entertaining. And I'm quite sure that the internal EMGuidance team would agree with the latter. Now, quickly, for those of you that may have joined this webinar late, good news is that this webinar has been recorded and you'll be able to access this webinar on the EMGuidance platform. An email will be sent out to you and you'll have access to this recording. Just before we go into our Q&A session, it's just a reminder for you guys to download the platform and use it. It is free and available in Kenya. Dr. Aruma, Prof. Aruma, are there any questions that you want to take? It is your opportunity now to all our healthcare practitioners in Kenya. If you have any questions, please send your questions through on the chat and we'll quickly answer them. So we'll give it a few seconds.
Thank you, Jonathan. I can't see any questions so far on our Q&A side. I'm looking forward for these questions.
While we wait for those questions, this is just a reminder that this webinar is CPD accredited. And again, we thank our partners at the Kenya Medical Association for really putting this together with us. And should you have any issues, I have put my email at the beginning of this presentation that you can send to me. should you have issues receiving your 3 CPD points. Just looking at if there's any other questions. It doesn't seem like there are any questions, but we are available online on the EMGuidance platform. Dr. Iruma, are you happy to close the session?
Absolutely. I just want to end it by saying that it's a privilege having you guys here. Sorry, I've got one question from Catherine. So let me go that. Are macrolides are safe to prescribe to patient known to have diabetic patient? Well, macrolides are antimicrobial that includes the erythromycin, which is seldomly used these days. It includes azithromycin and also includes the clarithromycin, Catherine. Your question is brilliant because there is no interventions with the glycemic control for the macrolides. However, there is an issue with the macrolides, which is the GI upset. Macrolides known to cause a GI upset, including abdominal cramps and diarrhea. And as all we know that this is the same side effect associated with metformin. And should the two medications be given together, we have to be very cautious. Usually when we treat patients with infection, Catherine, if it's a clarithromycin, it's going to be twice a day for 5 days. If it's an azithromycin, it's going to be only for 3 days. There will be no concern about using that in diabetic patient. However, there's few unfiltered and poor quality data shows that using clarithromycin beyond the frame of 5 days could have lead to masking the symptoms of hypoglycemia. I don't think that's right. And we need to stress on the fact that antimicrobial therapy should have gone in line with the antimicrobial stewardship program. Clarithromycin should not be given beyond the frame of the 2 weeks. And for that reason, using them in diabetic patients should be fine. However, in a practical, you may need to consider prescribing some probiotics to alleviate the situation. Now, the other point with the macrolides and diabetes is that we knew that diabetes from pathophysiological background can cause silent myocardial infarction. And macrolides are associated with a QT prolongation. So we have to be very careful. Should the patient start having symptoms of syncope or drop in the blood pressure, that might be an alerting sign that the drugs like macrolide are contraindicated. I've got, I think, another question from Adan. The 6 WHO steps of rational prescribing, that's absolutely amazing. I am a big fan of the 6 steps. However, you have to customize those 6 steps in your country because the 6 steps speaks about the P drug. And this is exactly what we talked about. The WHO 6-drug rational prescribing is the main reference to me, is the main reference for the Clinical Pharmacology Society. And I completely recommended everyone to go through that. In fact, we have a CBD in our platform and EMGuidance when we use the 6 WHO steps of rational prescribing as a foundation for that CBD. But thank you, Adan, for the question. Let's leave a few minutes, a few seconds for other questions.
Sure.
So, Jonathan, I can't see any other questions coming from my side. It was a privilege having you guys today. Thank you so much for listening to me. And I would like to say good night. And I'm handing you back over to Jonathan. Jonathan?
Thank you very much, Prof. Iruma. To all our healthcare practitioners in Kenya, again, a big thank you for joining us tonight. We wish you a safe journey home. And for those who couldn't make it due to the busy Kenyan Nairobi traffic, we apologize, but you will be able to have this recording on the EMGuidance platform. Have a safe evening. Asante sana, and we hope to see you again soon.
Thank you very much.